Good afternoon, everyone. Thank you for joining us. My name is Nick Larson. I'm one of the nurse practitioners for the anesthesia program here at Boston Children's Hospital. Thank you for joining us for the Surgery, Pain, and a New Method to Reduce Opioid Use webinar through the hospital system. For the next half hour or so, we're going to be talking about pain and specifically pain management during and after surgery, which is a topic of great concern among many patients and families that come through Boston Children's Hospital. Here at Boston Children's, we have a unique and an innovative form of pain management that is utilized to reduce patients' level of pain and improve their recovery times after surgery. I have two very special specialists here today. I have Dr. Waleed Ariashi and Dr. Matt Maluski. I'll let them introduce themselves in a second, but they're here to talk to you about pain management and surgical pain after surgery, and they'll answer any questions that you may have regarding pain management and related to surgery. We have the Q&A feature. If you have any questions during our presentation, please enter your question in the Q&A section. We'll answer all the questions at the end of the webinar. So Dr. Ariashi, I'm going to let you introduce yourself first. Tell us a little about yourself.
Hey, thanks, Nick. So I'm one of the regional anesthesiologists and pediatric anesthesiologists here at Boston Children's, and I specialize in sort of the use of ultrasound to deliver regional nerve blocks for patients. I also use it for diagnostic things in the acute care period and the perioperative period. So my specialty is to provide patients in this scenario with local anesthetics to targeted regions to try to reduce postoperative pain, intraoperative use of anesthesia, and improve their outcomes in general. That's kind of a little bit about me. I do a fair amount of teaching in this space and do spend a lot of time learning as well. And we're constantly evolving and developing our programs here to try to provide sort of the most cutting edge care for our patients that exists right now in the world. So that's a little bit about what sort of my interests are and what I do. And, we can talk about more fun stuff later, but that's the gist of what we're talking about today.
Great, thanks. And Dr. Maluski, tell us a little bit about yourself.
Perfect, Nick. Thanks for the intro, and thanks for everybody for being here today. Again, I'm Matt Maluski. I'm one of the pediatric orthopedic surgeons here at Boston Children's. I have a subspecialty interest in sports medicine. Most of my practice is the treatment of the injured athlete, particularly the young athlete. Again, I've done double fellowship training in both sports medicine and pediatric orthopedics, and have a big interest in working with Nick and Waleed and others on improving pain management after a lot of our outpatient surgery.
Fantastic, great, thanks. So without further ado, what we'll get into next is talking about pain management specifically in general. So Dr. Ariashi, talk to me a little bit about pain management. Why is pain management such an important topic when we talk about surgery in the pediatric population and the population in general? Tell us a little bit about why pain management is such a big interest to you and why we can help our patients.
Yeah, absolutely happy to. So, pain management, there are many facets of pain management, and they sort of tie together with the care that we provide in surgery. It is obvious to everybody that, there are certain surgeries that are needed in order to improve the functional outcome or improve patients' pain or recovery from some illness or some disease state or some pathology, fracture, tear, whatever it is, in order to take care of them. But in order to do it, there's associated pain with doing so. And if we can use leverage technology and clinical medicine in different ways, we can actually make that whole process just a little bit better. And that comes to a particular interest to me because I myself have had orthopedic surgery, for example. I tore my ACL when I was in internship training, and during that period, I remember the experience of the right from home, even from the moment that the injury happened to not being able to play sports to I'm sorry, give me 1 second. I'm just gonna mute myself and close Thank you for that. So you're muted, Nick. But
I'm gonna let you finish.
so I had surgery myself, and I remember just from the moment of the injury to not being able to play sports to sort of being anxious before surgery to going to the operating room, meeting everyone, and then dealing with all of the pain post-operatively, as well as the medications, the side effects that came with it, the sort of being in bed for a few days and trying to mobilize, and on and on and on. So that experience is sort of I'm able to share, and I sort of be empathetic with the patients that I take care of. And so knowing what I know within the specialty of anesthesiology and regional anesthesiology, I've sort of figured out that we should be able to do better, and we can provide better if we work with all of our teams and with the resources we have here. That we can actually do a whole lot better than what I particularly experienced. So we learn by experiences, and that's one of the more poignant experiences for me. It is important, and that's just on a personal level. Um, from a medical level, we know very well that poor pain management after surgery can have many complications, and I'm sure Matt can get into this a little bit more. But just to touch on some of the things that we worry about as much as any other doctors, we worry about patient factors. You worry about them getting back to the activities that they want to get back to. If they have a lot of pain, that's going to restrict it. How well they get back into physical therapy, that can become problematic. How well their wounds heal is another thing. On a biochemical level, we know that more pain is associated with increased catecholamines in the body after surgery. And that in itself can actually affect wound healing, that can affect even the surgical repair. So anything we can do to help patients. Lastly, children in and of themselves, when they experience a painful episode, that can actually cause long-term sequelae for how they perceive surgery and how they undergo procedures. For some, it can be pretty traumatic. So anything we can do to sort of improve that experience and make it a little bit better, we certainly want to leverage everything and anything we can do while minimizing all of the side effects and complications that are possible. So we're basically always trying to do the two things, right? Maximize the benefit, minimize the risk every single time. So that's why one of the reasons, and some of the reasons why it's important for me personally, but it's also important sort of at the medical sense. And there's other things we can talk about later, I'm sure we'll get into, such as opioid addiction, opioid substance use disorders, and so on in adolescents, but we'll leave that for further discussion later.
Thank you. Very in-depth. Dr. Malewski, from your perspective, can you talk about pain management? Why is pain management so important from your perspective, from a surgical perspective, in the recovery of your patients?
Yeah, pain management is key. Orthopedic surgery is very common these days, as you can hear. Probably almost every one of the panel members has had orthopedic surgery or has a direct family member who has. And so managing pain afterwards is really key to that. I do have some slides. Give me a second just to hopefully share my screen. So again, just as some background, here's some disclosures. I do some research, as Willie had mentioned, in this space. So we're always just trying to improve outcomes, both locally and nationally. So first, orthopedics covers quite a broad range of extremity type surgeries. And so I think it's worthwhile kind of going through a few of those, because folks on this webinar may be familiar or thinking about a loved one having one of these procedures, or may be confused by what orthopedics means in general. So orthopedic surgery, sports medicine, really encompasses extremity surgery as well as spine and hip surgery. Again, we can break it down into some of our subspecialty interests. All of the orthopedic surgeons here at Boston Children's, including myself, participate in trauma care, which involves fractures, which really means broken bones. That also includes soft tissue injuries, and does include infection. And so that can be infections without prior surgery, and it can also mean infections in the setting of prior surgery. Spine surgery, the vast majority of spine surgery in pediatric patients usually involves scoliosis. Hip surgery can be done both open and arthroscopic, depending on the specific pathology. Neuromuscular involves our treatment of conditions that affects the neuromuscular system. Cerebral palsy is probably the most common or widely known one, but there are many in that space, both congenital and developmental. And then we have some of my partners do more lower extremity surgery, which can involve deformity or post-traumatic corrections. I have partners who specialize in upper extremity, hand and elbow. And then I am one of the sports medicine arthroscopists. And so my practice involves really knee, shoulder, elbow, and ankle surgery, both arthroscopically and open. And then I have some partners who also do hip arthroscopy. So again, a broad range of extremity and axial type procedures, each of which can be, some can be minimally invasive and some like scoliosis surgery or hip surgery, open hip surgery can be very, very invasive. So, and the pain management for each of these type of procedures may be similar and may be vastly different. So again, pain varies after orthopedic surgery. There's lots of factors that go in. While we covered a few of these, including patient factors, but also the procedure or specific surgery factors can change how much pain is generated. Pain management needs to vary based on specific patients may have certain conditions that may make conditions more painful. And some surgeries may be more challenging to patients to get through. For example, the second time you have a procedure, or if you've had ACL done on one side, the second time around on the other side is actually usually goes much easier. Patients tend to know what to expect physically, emotionally. They're prepared for it. And so very often patients for second surgery require much less pain management or pain medications than the first time around, as an example. And again, as we'll talk about, some procedures or surgeries may be more or less appropriate for regional anesthesia. The vast majority of our orthopedic patients here at Boston Children's get general anesthesia. There are some unique characteristics where patients may not go under anesthesia or general anesthesia. Doing procedures without general anesthesia is much more common with my adult colleagues. The reason is adults are a little bit more apt to be comfortable or okay being awake during a procedure. Most kids do not want to be awake during their procedure. And many adults may have specific medical factors which make general anesthesia a lot more challenging to their overall health than kids. And luckily, most kids are pretty healthy and can undergo general anesthesia. So usually our regional anesthesia is supplementing that. So we traditionally think of pain management as what happens the day of surgery and the days after surgery. But in reality, pain management sometimes needs to continue for days or even weeks. And the reason is certainly most of the discomfort is usually significant in the first 48 to 72 hours after extremity surgery. We tend to think that swelling or the fluid that goes into or around a wound increases and sort of hits its maximum level at about 48 to 72 hours after a procedure. But certainly some folks can continue to have some degree of discomfort for days or even weeks after that. And that can affect both their functionality at home, their function at school. It can also function how well they do during rehab. And rehabilitation after orthopedic surgery is incredibly important, often as important as the surgery itself. We often say that 50% of the success of the surgery is my job as a surgeon, and 50% of the success of the surgery is the patient and the rehab specialist, whether that be physical therapy or athletic trainers, working with the patient afterwards to get them back to sports and activities. I tend to think of rehab in terms of three main phases. And again, this may be different in terms of the length of time you're in each of these phases, depending on what type of procedure you're having. Again, the first phase is wound management, swelling control, and restoring your range of motion. For example, knee surgery. This can take a few weeks to kind of get the swelling under control and then restoring your normal range of motion. Again, range of motion needs to be restored before you can really work on strength. A lot of times people want to skip right to getting strong after surgery, but the reality is you need a joint that has minimal swelling and good motion before it's really going to get strong again. And then the third phase is once you've restored kind of everyday strength, the strength that allows us to walk to school or to drive a car or to go up and down stairs, then we start working on what we call sport-specific training. That can include running, plyometrics, which really means jump training, cutting or pivoting. And again, that may be different for each athlete. The rehab may change if you're a football player versus a gymnast versus a dancer, for example. And again, pain management is important throughout that whole process. Again, we've talked about the immediate post-op phase where, and we'll talk a lot about that here, which can involve both the general anesthesia, regional anesthesia, and then medications that we take by mouth when we get home. Then there's sort of that rehab phase where most of the time people are off other types of pain medications, regional anesthesia is done. Occasionally folks will need some anti-inflammatory medications like Motrin or Tylenol during this phase. And again, it's important because pain can affect how patients feel physically, obviously, mentally, but also emotionally and socially. And I think those components are things we're actively trying to improve and also study here to improve those things. So which procedures are most appropriate for regional anesthesia? Regional anesthesia means localized medication in an extremity. Well, certainly extremity surgery, it's most appropriate for arm or leg surgery in orthopedics rather than spine surgery. Most of the time we're using this for non-trauma fracture care. So if folks have an acute injury, a broken femur, a broken humerus, most of the time, those injuries are associated with fairly significant swelling, which can lead to a syndrome called compartment syndrome, which is basically too much swelling in the arm. And so we need to monitor that swelling and how well a patient is doing afterwards. And so sometimes if the whole limb is numb from anesthesia, it's hard to get a sense of how well the swelling is improving or not improving. So sometimes we do have to back away from patients getting too much medication such that we can monitor their symptoms. And again, smaller procedures may be appropriate for local anesthesia, just around the incision, like you would use at the dentist's office, rather than regional anesthesia where we numb up the whole leg. And so how is that different? Very often people ask, well, you're doing knee surgery, so should I get regional anesthesia or not? Well, it depends on what type of procedure you might be having. For example, I've outlined 3 very common knee surgeries here. Again, the first one, knee arthroscopy for meniscus surgery, either a repair where we suture it back together or trimming it up if it's too badly damaged. Most of the time in our hands, this patient may get general anesthesia with a little bit of local anesthesia around those portal incisions. Again, small incisions, less medication needed. Let's go to a more medium-sized procedure, again, knee arthroscopy with patellar stabilization, in this case, MPFL reconstruction, which is a ligament reconstructed on the inside portion of the knee to better stabilize the kneecap. Again, this can often be associated with general anesthesia and usually with a single shot regional anesthesia block, which we'll talk about. And then third is ACL reconstruction. I think everybody probably knows somebody who's had ACL surgery. Very often in our hands these days, patients are getting general anesthesia and then also supplementing that with one of a home catheter, for example. So why is this important? Well, pain management can improve physical and also psychological readiness to return to sport. And again, that as a sports medicine expert and specialist, my goal is to get young athletes back to the sports that they want to compete in. And again, some of that is physical readiness, but a lot of it is mental and emotional readiness. And so we've seen that improved psychological readiness is associated with improved physical readiness. And so if you can improve pain management and you can improve psychological readiness, you can also improve physical readiness. And again, some of this pain management, some of this psychological readiness, which we've shown through some of our research, can vary depending on your age and gender.
Well, thank you, Dr. Malewski. That was a very comprehensive depth and dive into orthopedic surgery here at Children's. what's common, what's uncommon, what to expect as far as the surgical procedures we have here at Boston Children's Hospital. So I think from hearing both of our doctors here, you can definitely see how pain management in conjunction with surgery, we work very closely together. So Dr. Ariyashi, the topic of nerve blocks was introduced by Dr. Malewski, and this is where we have our unique and innovative practices to offer this alternative to opiate or narcotic medication. So can you bring us into a little bit more of the regional anesthesia world? What is regional anesthesia? What is a nerve block? How does it work? And how do we think it can help patients?
That's a great question, Nick. Thanks for getting into that. And yeah, so regional anesthesia is the use of primarily local anesthetic-based medications, or the delivery of medications into a targeted area of the body to reduce and render it sort of with lower pain or lower nociception. What that means is, for example, in a classic nerve block, we find the area of surgery or injury or fracture or whatever the case may be, sometimes burns, but we basically, or cancer, tumor, and things like that. And then we find where the nerves where the pain signals travel through which nerves, and we target it by placing local anesthetic around the nerves. And local anesthesia works by basically blocking the signal from traveling up through that nerve to the spinal cord and then up to the brain to tell the brain, ow, that hurts. Because that's the normal pathway for the body to tell itself that, hey, this is dangerous, or that hurts, or this doesn't work, or that's hot, or whatever the case may be. So that by using local anesthetic, we are effectively applying, thank you. We are effectively applying local anesthetic in a targeted region to block those signals. That has many benefits, one of which is obviously there's less pain associated with it, but also the body, by not sensing that, doesn't produce as much stress hormones within it to deal with that added pain. What does that mean? That means under anesthesia or without anesthesia, this can be done. The body doesn't need as much to reduce, doesn't need as much medications to reduce it on a systemic level. So we don't have to, for example, if someone's under general anesthesia and we do a block, you don't need as much general anesthetic medications to accomplish the same thing of keeping a patient asleep, because their brain is not getting constant signaling telling it, ow, that hurts, ow, that hurts. And then we need to give more and more medication, escalating levels of medication to keep someone asleep and to reduce their blood pressure, to reduce their heart rate, and to reduce all the things that come with a stress response. And that's one of the big benefits. The other thing is, after the surgery, that also allows a patient to have less pain. Now, we do it a little bit differently here in that we have we have some innovative techniques that use a lot of what's used in other areas, but we combine them in different ways that are not necessarily sort of widely practiced yet. So we're innovative in that way. The other thing that we can do is that for patients going home, as opposed to just having a singular injection, which might last 12 hours or no block, we can actually leave continuous local anesthetic injections. So imagine, if you go to the dentist and you get a injection of local anesthetic above your gum for a root canal, that usually wears off in a couple of hours. Our local anesthetics, if they're given as a single injection, will last about 12 to 15 hours. But if we left a catheter, if you can envision a catheter being left in there and have continuous local anesthetics, you can run that for a number of days, which is the peak period of pain, which, as Dr. Malewski mentioned earlier, that usually ranges anywhere between 24 to 72 hours. So one of the innovative programs that we have is a program called the Be Happy program. And essentially what we do is we run these continuous infusions for patients even as they go home, so that the local anesthetic doesn't wear off immediately. And they have pretty good pain control and coverage from that block for the next few days. Typically, the patients who we match the type of block with the type of surgery appropriately, they will usually not require many other medications to keep them comfortable, to be able to sleep, to not have side effects of those other medications, namely opioids. So that's one of the programs. Now that program is evolved. It's no longer just sort of doing blocks and sending patients home. We have a very robust program that involves basically be connecting with patients way before they even ever have surgery, talking to them about their risks, the benefits, their options, and then really coming up with a dedicated plan, especially for patients with a complex history or who have, have had experiences in the past or who are really worried about, how their pain management will be. We connect with patients ahead of time, especially as they talk to their surgeon or as they talk to us directly. We can actually come up with a very robust plan for them before they come in, and we'll communicate by email, by Zoom, by phone call, whatever method we need to do, and then we'll follow them even after surgery for the next up to 2 weeks, essentially, and more thereafter if they need further care. And this is a coordinated effort between us and the surgical group, different surgical groups. And I'm sure Matt Maluski can talk a little bit more about that. But our program is a little bit more of a program and not just sort of, oh, we do blocks. We do a very comprehensive transitional type pain program.
Yes, very involved, very hands-on, something that I myself am involved with, working with Dr. Ari, actually working with Dr. Maluski. It is a very in-depth program where we identify patients and are choosing the correct or the most appropriate regional anesthesia approach. Dr. Ariashi, can you just talk about the Be Happy program a little bit more? How long has it been around? What innovations does that program specifically offer to Boston Children's patients compared to patients at other institutions?
Yeah, so the Be Happy program was conceptualized probably back in 2018-19, and the launch of it began in 2020. And essentially, it was this program where we get more involved with our patients and we follow them before, during, and after surgery. And as we mentioned earlier, for some patients, we're able to place continuous local anesthetic infusions after surgery. And then we stay in touch with them by text message-based communication and, if needed, phone calls, as well as a Zoom 3 days after their surgery. Even when they leave the hospital, we're still in touch and engaged with our patients. We stay close with our patients before, during, and after surgery. And that's the program. We do it a little differently than other centers, I think, because we're so connected with our patients. A lot of other centers may do sort of blocks and they may send patients home with catheters, but they don't necessarily have that robust level of being in touch with our patients and being connected with our patients. We really care about that, and we believe that the relationships we have with our patients are paramount. We know that our patients undergo many experiences, some of them, medical in the sense of like physical stuff. There are patients who also have social things. They have psychological things. There are many sort of facets to a human being and to a patient. And we really try to stay engaged with that whole process and offer services where we can and in every possible way we can. We do leverage everything that Boston Children's has to offer in order to do so. So I think that's what sets our program apart from many other centers. We've had the fortune of learning from other centers. It's not to say that, other places don't do it well or anything like that. It's just that we have been privileged in the sense of learning from those centers and actually having those folks teach us some of the things that we were able to build well early on, or because of some of the learnings of other centers. But I think we do it really well, and I think our patients, feedback and information that they give us on what could be improved, what could be made better, is we do take that to heart, and we do review it actually on a regular basis. And we make changes accordingly. And that goes both for us as well as our surgical colleagues who I know do that. And then we stay in touch, as well as our pain service who we work with. So I think that's what sets us apart. It's really our patients and our commitment to our relationships with our patients.
And then how about the safety of regional anesthesia as a whole, Dr. Ariashi? We've talked a little bit about avoiding opiate use and having those known side effects from those medications. Talk to me about the safety, the efficacy of regional techniques in general.
Yeah, so that's a great question. A lot of regional anesthetics, when they were performed, the very first regional anesthetics actually were performed in children more so than they were in adults. And not a lot of people know that, but the first neuraxial or central nerve blocks were actually done in children. And then over time, it was picked up by the adult world. And then for a period of time, there was concern about doing them in children because they were done under general anesthesia. As the years have passed on, the safety efficacy have been studied widely in thousands and in some cases hundreds of thousands of patients, and safety is pretty well shown. The likelihood of complication from regional anesthetics is less than 0.02 to 0.04%, which is really, really small. In fact, in some cases, the likelihood of a car accident is much higher than an injury from a peripheral nerve block. So at this point, it's very safe. And what's made it really safe over time is actually the use of ultrasound. Ultrasound technology has gotten so great over time that now we're able to see muscles, nerves, tendons, vessels, and other important structures like lungs and all the things that we want to avoid. But we're able to drive needles where they should be and really position the local anesthetic at a very targeted location within millimeters. So being very, very accurate at doing this has made it really safe over time. And from a safety perspective, it is one of the safest procedures you can get under anesthesia or in the anesthesia world. So that's a safety. As far as efficacy, there's a lot of studies right now that are going on related to different types of blocks and different types of surgeries, and trying to figure out which type of block works best for which type of surgery. And that's an evolving process. Now, there are some very well known that we practice based off of those studies, and there are certain procedures that we do pretty routinely with specific blocks. But in terms of efficacy as a whole, the efficacy of regional anesthetics in terms of the benefits that we're looking for is definitely there. The question of whether which block versus this, that becomes an academic thing for us on our side of clinical medicine. But when done well, and when the block matches the actual surgical procedure well, it is one of the better analgesic modalities that exists. In fact, there is this thing called the pain management pyramid. And in the pain management pyramid, it basically, on the base of the pyramid, represents the first sort of line treatment modalities for patients. And this is in all of pain management. This is classic teaching. A long time ago, when ultrasound technology and when regional blocks are still being developed, one of the first things that people used were they would use Tylenol and Motrin first. That would be the bottom of the pyramid. Then it would move up to different categories. And one of the middle things was to use opioids. Obviously, as everyone is very well aware from the news and from information that's been put out by the CDC about the risks associated with opioids and some of the things we've seen, some of the national problems we had with the opioid epidemic, that narrative has changed. Now, one of the earliest things to do is consider things like, very benign things like Tylenol, Motrin, and so on, when indicated. And that would be at the base of the pyramid, along with regional anesthetics. So that's actually become one of the baseline things to consider for pain management in general. And then it builds upon that with the very last thing being opioids. So as far as efficacy, it is pretty widely accepted in both adults and children at this point. And in terms of safety, it is pretty well established.
Certainly sounds like a good option compared to some of the other options that are out there. You talked about the pyramid a little bit. Certainly seems like a better option than having to take a lot of medicine after surgery. So Dr. Milewski, Dr. Ariashi talked a lot about the benefits of regional anesthesia from his perspective, both as pain management and as far as the general anesthetic. What can you tell us about your experience with your patients and regional anesthesia, seeing them in clinic, seeing them in follow-up after surgery? What's your experience been like?
Yeah, it's a great question, Nick. And Waleed did a great job kind of explaining how it works post surgery or during surgery. After surgery, the benefits of regional anesthesia, you can think of it sort of three phases. One, it helps folks go home often the same day from procedures and no longer need to stay over in a hospital, which has some tremendous benefits to the patient. Get to go home, get to sleep in your own bed. Parents also get to sleep in their own bed. Patients tend to be more comfortable at home. Sometimes families worry that they're not getting the full benefit of having a nursing team right there. But like we said, we're very connected. Our not only our anesthesia team connected to the patient post-operatively, but the surgical team and our nursing team at our outpatient surgical centers are very connected. So it certainly allows us to do more procedures on an outpatient basis. And there's some benefits to, not having to stay overnight in a hospital around other sick kids. And so number one, I think regional anesthesia helps folks get home sooner. Number two, as Waleed covered, it helps folks decrease the amount of pain medication that they might need at home, namely narcotics. Again, narcotics were developed for exactly this reason, post-operative pain management. So sometimes folks worry that narcotics should never be used post-op. And the answer is, well, sometimes we do need to use it to supplement the other things we're talking about here. But our goal is to try to minimize it as much as possible for all the reasons we've talked about. In the time before we were doing a lot of regional anesthesia, we did a couple studies here at Boston Children's and found that most folks needed about 2 to 3 days of narcotics after common procedures, such as ACL reconstruction. Again, I think we've vastly decreased that to where maybe 20% of folks may need some narcotics if they're getting the appropriate regional anesthesia and things are working well for them and they're staying ahead of it with Motrin and Tylenol. And so the second benefit is it definitely decreases the amount of narcotics and other medications we need to use post-operatively. And three, it also really helps folks in that perception of surgery post-op. And surgery in many ways is trauma, right? It's not fun to have surgery. Nobody wants to have surgery. And most of us have had to go through it before, and we've done well and we've done okay. But anything we can do to make that experience better or less traumatic, especially for kids, really increases kids' awareness and perception and mental health and psychological and emotional health. And so by giving them good pain control, we can increase their overall well-being, and that's been shown both at our institution and others. And so it's really a team effort, but I think that the regional anesthesia program has definitely helped our patients for other reasons we just talked about.
I think you hit the nail on the head where it is a very much a team mentality where you have a patient coming in for surgery. And it's not just a patient who's operating in a silo. It is a patient that's being followed by the regional anesthesia team, by the anesthesia team in general, and then even following them after surgery. So really speaking to the multidisciplinary approach to these patients who may just seemingly be coming in for a routine surgery, but feel like they're heard and feel like their plan is tailored towards them. And just a little piece to getting out of the hospital a little early. I always tell folks that it's easier to recover on their own couch with their own Netflix password as opposed to the hospital TV. So getting home after surgery is certainly an added benefit. Excellent. Do either of you two have anything else you'd like to add about pain management, about regional anesthesia? Any final thoughts from either of our specialists?
Yeah, I can add, just to echo Matt, and I think what's already been said here quite a bit, that pain management in children is a huge topic, and is multifaceted and is very unique to each patient and requires a lot of multidisciplinary thinking, planning, and coordination. And that's really what we're trying to do by being in close touch with our patients and having that close relationship with them. I don't think, no two patients are the same, and their histories are not the same. Their comorbidities are not the same. Their social situation is not the same. And so each person really does require a tailored, customized approach that really hones in on them. Now, of course, there are patients who have very similar backgrounds and similar experiences, but each patient's a little different. So, what we presented here just kind of gives a glimpse of some of the things that we're doing, some of the innovation that we're practicing and how we approach it. But there are certainly many other ways that people have approached it and will take care of patients. And this is just us sharing our story and sharing what we do and how we can help patients. But what one patient may get, another patient may not, and it just is a customized process for each patient, and that begins from the moment that you come to our center to when you leave here and go back home. And we get patients from all over the world, really. And so you can imagine that when we have that diversity of patients, you have to have a diverse capability to provide diverse care. And that's what we really try to do here. So just wanted to let folks know that there are so many other aspects of pain management that we won't cover in a short webinar. And I'm sure there are tons of questions and tons of thoughts, but we ask people to just, reach out to us. We're here, we're available.
One of our questions came in that kind of tied into what you were just talking about, Dr. Ariash, is when you talk with families prior to surgery, what are we taking into consideration when we're tailoring their pain management plan? We talked about a little bit about specific types of surgery and specific regional techniques, but what about the patients specifically can we take into consideration when formulating a pain management plan?
Yeah, I can go ahead and answer that. I think Matt wanted to say something
sorry.
in general first. Matt, were you going to say something, or should I just jump in?
No, I was going to echo most of what you said, and I was going to also plug our Boston Pain Clinic. So we do have, in order to tailor every patient's care appropriately, some patients may have more complex issues medically or pain-wise. And so there's always the opportunity to sort of have a preoperative consultation with our pain specialists to kind of understand where, the background of each patient and what special needs they may have. And so that's one of the things I think we do uniquely here. So I was just going to dovetail on what you were saying. But if you want to handle that first question, I'll defer to you.
Yeah, absolutely. And this actually goes right in line with what you just talked about, which is how do we customize the care? What do we look for in patient history or in their background to do so? So, for example, we have patients who have had 20, 30 surgeries, right? Who do not have normal anatomy, who do not have normal sensation of their extremity or of their body. That's not just extremity. We do, there are approaches we take for thoracic procedures, for back procedures, for abdominal procedures, and the list goes on. But we take into account their medical history, right? What comorbidities they have, what allergies they have, what medications they take that may or may not sort of affect the approaches that we do and what we can offer them. What medications have worked well for them in the past? Do they develop severe nausea and vomiting? Is it, how is their pain experience? Some patients come in with a baseline pain of, really high, severe pain or chronic pain, what we call chronic pain, for many, many years. Some patients come in, with no pain, and they just have something that they need repaired. And then there's also anatomical variations. So some patients, are born with congenital anomalies that we have to figure out a way to take care of them and provide the most optimum pain plan. And as I said before, some patients take certain medications that may impact opioid medications. They may impact their liver. They may impact, whether they bleed easily or not, because if they're on anticoagulants, or if they're, and then there's other factors like surgical factors. So if patient is having a procedure where they'll need special medications after surgery, that may make them more prone to pain, or that might make them more prone to nausea, vomiting, or that might make them more prone to nerve injury, or that may make them more prone to bleeding. All of these factors have to be considered when we're evaluating, what is the ideal plan. And our plan is not, we don't just provide, for example, just a plan around regional anesthetics. We provide a plan around what medications they can take, what fluids they should take, what their anesthetic, even their intraoperative anesthetic may be based on what we're doing. So all of these things get affected, even whether or not you receive an airway for a breathing tube, for example, during surgery or not, may be impacted by what we do, as is the age, the appropriateness of what the patient wants. Some patients want to be heavily sedated. Some patients want to be moderately sedated. And so there's many, many factors we have to consider for each of these scenarios. And as well as like the position of the patient during surgery. I mean, the list could go on, and on and on and on, but there are many, many variables that we have to consider for each patient to create that sort of tailored approach to their pain management. And as Matt said, one of the resources we tap into regularly is our pain service, which sometimes, we'll have a patient with a very complex history where we want to tweak some of these things just from a pain management perspective, and we'll connect them with our pain service. The pain service will actually see them in clinic or through Zoom, look at their medications, do a physical examination, figure out what their outlook is on surgery, and they may provide a number of referrals and services. For example, they may make medication modifications. Are they taking any medications? What do we need to modify? Do we need to add a medication to prime them for surgery even before they come in? Do they need special type of physical therapy or psychological therapy, social adjustment, or social care, social work? There are all these other factors that we sometimes consider before they even come in, and we optimize the patient so that they do well after surgery, as opposed to being sort of an afterthought. It's already sort of thought ahead of time, if that makes sense.
No, it's fantastic. I think it just goes to show that we're doing the best for every patient. There is no cookie cutter patient, so every patient is unique and has unique needs. So we're doing the best we can for all those types of patients. Dr. Malusi, question for you. Have you seen this type of pain management? How do your athletes recover by utilizing regional anesthesia techniques? Do you find that they are able to return to function earlier? Do you find that reducing the amount of PO medications affect their recovery or their return to sport in any way?
Yeah, it's a good question. I think the short answer is we're still trying to define that because it's a big research interest of myself and of our department, and it is certainly a hot topic across the country. Because return to play is often so many weeks or months after your surgery, the immediate postoperative pain is often very split from that. It's weeks or months later. But I do truly think and believe that good postoperative pain management improves initial outcomes, which then also needs to have a trickle down or downstream effect on folks doing well later. I think if folks really struggle their first few weeks with pain management after surgery, for example, knee surgery, things like stiffness can be a bigger problem. And if your knee's stiffer for longer, then you're not able to work on strength as much. And so then some of your things may be delayed. So yes, I think that there's some evidence, and we're still working to define that even better.
Fantastic.
Yeah, and just to add, this is a really, it's actually, I commend Dr. Maluski and his team and, working with us on this. It's actually a very hard thing to study because as we've talked about how variable it is from patient to patient, you can imagine that it is also variable from physical therapists, from social situation of each patient, from the environmental factors, and any number of things that trying to control those variables. So from a research perspective, controlling those variables is actually really, really hard. But that being said, I shared Matt's sort of experience and with how patients have recovered here and how they do that. The short-term benefits are visible and palpable to us, and we think that that has a trickle-down effect on the long term.
Great, thank you both. Dr. Ariyashi, we talked about the safety of regional anesthesia. We talked about some of the potential side effects. How about negative outcomes or injury that could be related to regional anesthesia and the prevalence of incidences like that?
Yeah, so the likelihood of direct nerve injury from local anesthetic is actually really rare, as I described earlier. When they do happen, typically the injuries are short-lived. So most of these patients, if they develop an injury, they will have what we call neuropathic symptoms. And those neuropathic symptoms usually manifest or show up as numbness or tingling in a sensory distribution of the nerve where the nerve was. And in those situations, the vast majority of them resolve within 2 weeks. And even if it still lasts beyond that, almost all of them resolve within a month, and very rarely have we ever seen anything go beyond 3 months. But yeah, that's how they usually manifest when they do manifest. There are case reports of patients who have had a nerve injury where it's affected their motor function. Again, that's extremely rare. But usually we have a very robust program for patients if they ever developed symptoms that lasted beyond a certain number of days. That's why we follow our patients for minimum 2 weeks with plans to expand that. And then we of course have our surgeons seeing the patients post-operatively as well, assessing their sensory, their motor function, their return to activity, and so on. So this is one of the big reasons why we believe having a very close-knit relationship with our patients and following them is so critical to doing so, because if issues come up, if they ever do, and when they do, we're right there with them. We don't just sort of, oh, you have an issue, that's what it is, and then we walk away. No, we really do stay in touch with our patients and kind of walk them through it and be with them there as they get better.
Fantastic. See if we get any other questions that are trickling in.
Yeah, there's a question there. Do you recommend preoperative physical therapy for certain surgeries, example, knee surgery? I'll let Matt answer that one. I think I know the answer, but
yeah, it's a great question. The simple answer is yes, for certain surgeries, prehab, what we call rehab before surgery, is recommended. This is probably most strongly recommended in ACL surgery. So not necessarily every knee surgery, but definitely in ACL surgery. The idea is that by doing physical therapy before surgery, a couple things happen. One, it decreases your swelling. It improves your range of motion before surgery. So less likely to have a post-op stiff knee if you go into surgery with a good working full range of motion knee. And two, there is some neurologic and psychological benefit to understanding the rehab principles that you're going to do afterwards by doing them before. And so that can help not only with range of motion and strength, but also pain management. Like if you know the rehab things you need to do afterwards, then you're prepared for them and they seem to hurt less.
Excellent. Well, I don't see any more questions in the Q&A. I thank everybody for joining us this afternoon. I hope that you found this webinar informational. We talked about a lot of different things today. If you have questions, feel free to reach out to us, whether at the home regional anesthesia program, the sports medicine team, or the pain treatment team. We talked about all three today. You can feel free to reach out to us with any additional questions. Otherwise, I'll let Dr. Ariyashi and Dr. Maluski sign off as well.
Awesome. Thanks so much for being here. We appreciate the attendance, and great questions, and appreciate Nick and Waleed for leading our regional anesthesia program.
Yeah, thank you all. I do appreciate the time to kind of share our experience here and talk with folks live. Matt, thank you so much. Dr. Maluski, Nick, thank you. And our Boston Children's team for putting this together. As we've said, we are available to everyone, and we do want to thank a lot. Now, we're just kind of the faces here, but we want to thank the numerous amount of people that make this all work for our patients, from nursing to all of the other surgeons in the background. There are too many to name, to all of our anesthesia team and regional team members and nurse practitioners and all the leadership people that do make this work. We're just sharing that information. We're just the voices, the talking heads for it right now, but I think everybody can understand that this takes a whole large team for it to happen. Just like any other sports team, no one player is more valuable than the other without the whole team.